Good afternoon, everybody. My name is Dr. Stacy Lindau. I'm the founder and chair of the board of MAPSCorps. MAPSCorps is an acronym for Meaningful, Active, Productive Science and Service to Communities. And today's session is one expression, I think, of the meaning of our acronym. Our vision is to cultivate scientific minds, healthy people, and invested. And for 13 years now, MAPSCorps, which grew out of an organic, earthy collaboration on Chicago's South Side, we have been operating, employing, and training youth to become the scientists and experts of the assets in our communities. MAPSCorps has grown over time. We started with 6 communities on Chicago's South Side, including those that immediately surround the University of Chicago's campus and the East Side, South Chicago communities. And in 2019, we mapped the assets of more than 60 community areas of Chicago's 77. We scaled back and focused a little bit in 2020, but we still employed and trained youth in community asset mapping this year. Survive this painful time, this pandemic, and I want to just hold space for a brief moment for each of us to keep in mind the hundreds of thousands of people who we have lost in this country alone as a consequence of this pandemic, and all the people who've been touched by it directly or indirectly. And certainly I'm so grateful to all of my colleagues, healthcare workers, who along with other essential workers have helped us get through the phases we've been through. Future. I am thrilled today that we're bringing together this esteemed panel of people facilitated by Natalie Moore to talk about the COVID-19 vaccine. Can we trust it? What do we need to know about it to think critically, to be healthy people, to be invested citizens? I'd also like to introduce my colleague, Attrition Lamumba, who is a MAPSCorps alum and who has been the project coordinator for MAPSCorps for the last couple of years. I'll turn it over to you. And thanks again, everybody, for joining today.
Hello, everyone. Good afternoon. My name is Attrition, and I'm the program coordinator here at MAPSCorps. I began my journey at MAPSCorps at GAGDC, that's the Greater Auburn Gresham Development Corporation, as a field coordinator studying economic development with my group of mappers. I found the experience to be formative, and when the opportunity arose, I took it to work full-time with MAPSCorps. So at MAPSCorps, we train youth to produce high-quality data about community assets that everyone can use to improve the human condition. MAPSCorps was founded because our lives depend on our neighborhoods, but we lack high-quality information about where to go for the resources we need most. MAPSCorps engages youth to close the information gap so we can access the resources we all need to do good, stay well, and live long. This webinar is important because COVID-19 has affected the lives of everyone, including many of our young people whose families have also been affected. We wanted to facilitate the dissemination of accurate information when it comes to COVID-19 and the vaccine while engaging all of you. So I'd like to introduce our amazing panelists. First, we have Dr. Kelly Michelson, Professor of Pediatrics, Bioethics, and Medical Humanities at Northwestern University, Feinberg School of Medicine, as well as the Director of the Center for Bioethics and Medical Humanities, and an attending physician at Lurie Children's Hospital of Chicago. We also have Seema Shah, an Associate Professor of Medical Ethics and the Associate Director of Research Ethics at Lurie's Children's Hospital, as well as Northwestern. Then we also have Dr. Anthony Williams, a cancer biologist at the University of Chicago and the participant in the Moderna vaccine clinical trial. Regrettably, Dr. Erin Paquette was not able to join us this afternoon. I'd also like to introduce our moderator, WBEZ reporter, author of The South Side, A Portrait of Chicago and American Segregation, winner of the 2016 Chicago Review of Books Award, Natalie Moore. So Natalie, take it away.
Great. Good afternoon, everyone. I'm really excited about this conversation because I am ready to learn myself as we are getting toward the light of the end of the tunnel with a vaccination. I first would like the panelists to weigh in on some of the history between the distrust between government and the medical field and Black communities in particular. I'm sure that a lot of you all are seeing the memes going around, and even if they are not rooted in actual facts, they're still rooted in emotion that people are really afraid. Thinking, they bring up the Tuskegee experiment, they bring up sterilization. So we could just jump off the conversation by talking about some of the historical mistrust that's there.
Hi, this is Seema. I can talk a little bit about the historical mistrust, and I wonder, I think a lot of times when we're being sort of optimistic, we say, oh, it's in the past, but we have to be honest that it continues through to the present day. So the Tuskegee syphilis experiments, which many people are familiar with, were studies that where the scientific reasons for doing them didn't make any sense in terms of the way that they did them. The plan was initially to look at how syphilis progressed naturally in people who had it, and to compare Black people to white people, but they didn't enroll any white people. And then the men who were enrolled in that study were kept in that study for years, even after a cure was found. They weren't given that cure, and they were told that they were getting the medical treatment they needed, when really the researchers just wanted to see what would happen. And those men then infected their families, and which led to consequences for them, but weren't informed about them. So it wasn't until the 70s, when that was exposed in the papers, that the government stopped the study and started to really consider the history of medical research and think about better ways to conduct it. So that is kind of just one of many examples where people who were seen as vulnerable or easy to exploit and research and learn from without them knowing what exactly was happening to them were taken advantage of. These examples led to the creation of the modern oversight system for research. And so we now have institutional review boards, we have ethicists who work on studies, we have regulations and laws that make sure that people are informed about what's happening to them. So there were responses, but the distrust, I think, that exists today is still, it's something that's rooted in rational perceptions of how people are treated. And we know there's still a lot of implicit bias in how Black people are treated within the medical system. There are examples, for example, in sickle cell, the pain that people experience is often discounted or poorly treated. So there are many examples that persist to this day that I think can explain the distrust that people feel. But I think I would love to hear perspectives from others on the panelists about that as well.
I guess I would just add that I feel like medicine is sort of another large institution that I can see a lot of communities feeling sort of frustrated by how they're interacted with. So, whether it's getting a loan, whether it's owning property, whether it's where you go to school, whether it's how you get your health care, I feel like these are all systems that have been problematic in terms of how different groups are treated, and so I think all of that spreads to healthcare. And then as we've seen over the last 9 months, it's striking that certain communities have suffered disproportionately during this pandemic. It's inescapable and it's ubiquitous. So it doesn't matter what state you look in. You're seeing similar patterns across the country. So I think that just sort of waters the seeds of mistrust even more.
And Anthony, you are, they've gotten a lot of press recently because you're involved in the trials, and you're motivated not just by being a scientist, but also being a Black person.
Absolutely. So the decision to enroll in the Moderna trial was definitely not one I took lightly. It involved a lot of kind of thinking and going back and forth, and obviously for the scientific reasons and for the benefit to public health and sort of thinking in a communal sense, that definitely factored in as a reason. But to the points that Kelly and Seema have been making, what I identify. So in my own kind of day-to-day practice, I do prostate cancer research, but in particular, I do trying to understand the biology of how these disparities persist with Black men in prostate cancer. Higher rates of diagnosis, higher risk of death from the most aggressive form of prostate cancer. And so a lot of these problems overlap generally in the healthcare space and in society at large, as Kelly just talked about. And I think it gets down to Black people being reluctant to enroll in vaccines or in clinical trials or in so forth. That's a symptom of the problem, right? The real problem is the culture of distrust. So no matter what I say, no matter what kind of data I bring to you about safety or reasons that you should be doing this or how this can potentially impact, in particular, your community, if you don't fundamentally trust me, then you don't trust anything that I'm going to say, right? So I think what's required is a very ambitious and ambitious effort to reorganize the trust and to break this culture, right? And it may take several years or maybe a generation. It took longer than that to put us here, right? The Tuskegee experiments that Seema, spoke about, that was 80 years ago, right? So, and following that, you can name multiple instances that things similar to that have occurred. And so my enrollment in the clinical trial represents what I believe a step from our side of this coin, right? It's the biomedical research and healthcare apparatus on one side, and there's plenty on their to-do list to help dismantle this culture that we currently live in. But then there's also work on our side, right? We have to enlist in this process. We have to claim some agency over our healthcare and over our wellness and our place in this space. We belong there. Our data need to be contributed to these trials and need to be represented. And we need to be represented very literally in that space, because our data need to be a part of the solution. And when they aren't a part of the solution, then it helps feed into this cycle. We get left behind. That vaccine is for them. It's not for us. And so this helps feed this cycle ongoing. So this is a very kind of forward and public thing that I can do to start this conversation with my peers and friends and community at large.
Does your shirt say vaccines?
Vaccines cause adults.
Great. And that's a good segue into my next question. If we could just take a moment to talk about vaccines at large. The thing about vaccines is that they've done such a great job that people don't think that they need them. And we have an anti-vax community that seems to grow, and now it's coinciding with having to deal with COVID. I'm wondering if you all could not so much convince people, but what does the evidence say about harm that vaccines cause? If you could just do some of that little, in general, myth busting about vaccines.
Yeah, I think I can jump in this. I think maybe it would help to have a quick kind of Cliff's Notes crash course biology, high school biology kind of refresher to kind of, give you an idea of how this thing started, what science did, and where we're at now. So at the very start of this thing, at the ground zero, like, so we're in China, people are coming into the hospital, they're getting sick, they're all exhibiting the same symptoms, nobody's responding to any other treatments, a lot of people are dying, right? So something's wrong. So scientists, the first thing they do is they isolate this virus that they have no idea what it is, and they sequence it, they genetically sequence it, right? And so now they have this full sequence of all of the information that goes into building the components of the virus that then come together and do harm, right? And in addition to that, there is a way which they also have accomplished to map what gene exists in what part of the sequence. So I can, look over here, imagine if you have a cookbook and you flip to mac and cheese. And then on page 68, it's the stuffing. And on page 97, it's the greens, right? It's a volume that helps you put together Thanksgiving dinner, right? So they have these genes mapped. And so what they are doing is synthesizing a genetic subunit called messenger RNA, right? So the messenger RNA from the DNA is the piece that's used to encode the proteins that then come together and make a virus. And what they're doing specifically is synthesizing a messenger RNA copy that provides the information for a component of the virus called the spike protein. So the spike protein is the piece that actually helps it infiltrate your lung cells to then propagate and spread throughout your body. So they synthesize this piece and they encapsulate it in this nanoparticle. Is coated with lipids. So it's called a lipid nanoparticle. And then they place it into a syringe and they give it as a vaccine, right? So what that's doing is it's going into your body, and then your body sees this messenger RNA and uses its own natural machinery to make a protein from it. So you're making a component of the virus, not the full virus, right? And the protein is what, I'm sorry, my son is
I
chirping in my ear.
I locked my door. I don't know what could happen. There may be some banging.
Right, got you. So so now this protein is foreign to your immune system. And your immune system will build antibodies and immunity against it. In the event that you, in the real world, are exposed to the full virus, it already is primed and ready to attack the virus and keep it from creating any severe problems. And so that's kind of what was happening from, the sequencing happened in November, and they made it public, right? And then the vaccine development and figuring out which part of this sequence we want to target, that was a couple months. And then checking to see if it was safe before we even checked to see if it works, that was a couple months. And then testing in humans, and then now we've arrived.
So I just can't wait to post this video on Facebook, because all of there's a fine line between skepticism and then the armchair scholars who think they know chemistry or medicine or anything, who are, spreading misinformation. So I'll just say, if you can understand what Dr. Anthony Williams is saying, then I may be more willing to hear what your thoughts are on how the vaccination came to be. Kelly, were you going to jump in?
Yeah, I just want to say that what I really appreciate about what Anthony just did is he talked about the facts, and I just keep telling people that knowledge is power. You had asked, Natalie, how do we get to this place where we have vaccine hesitation? Part of it, a huge part of it, comes from misinformation, from information that are not facts, and you know, I'm a little bit of a skeptical patient and doctor. So as all of this is coming out, I have found myself wanting to know more and more and more about it. And I can just say from a personal perspective that the more I learn about this vaccine, the more comfortable I feel with it, which I think is good. So I just want to encourage everyone to find out as much as they can from reputable resources about how it works and why we think that vaccines in general, but also this vaccine, are safe.
And if I could add a little bit, I think, you know, we've all kind of been learning as we go about the process of developing vaccines. So this was something that I used to work on, and now I feel like I understand it a lot better because we've watched it happen in real time. So as Anthony was saying, when you get to that point where you have a vaccine and you think it's going to be safe, you still have to test it in people. And a lot of people, I think, have been didn't really like the name Operation Warp Speed and had concerns about this idea, you know, it's going so fast. How can they tell that it's safe? It's true, this is faster than we've ever seen before. The last time that a vaccine was produced, you know, at great speed from the time we've identified the virus to the time it's being given to people was 4 years for mumps. So the fact that we're doing this in about a year is remarkable. And the reason is, I think there are lots of reasons for this, but you know, some of them are frankly tragic. One of the reasons is that when you give people a vaccine, you want to see if it works. You give some people a placebo and some people the actual vaccine, and you wait to see if there's a difference in the number of infections in the two arms. And because the pandemic has been so poorly controlled in our country, partially because of a failure of our federal government, it didn't take that much time to see a big difference in infections and to show that the vaccine did, in fact, protect people. Another way that this was sped up, which is a little more hopeful, is that a lot of money was thrown at the problem. So instead of, usually about 10,000 people are enrolled in that last stage of testing to see if the vaccine works. And in this case, for each vaccine, they've enrolled about 40,000 people. And finally, usually there's you test the safety, you wait, look at the data, then you test, do we think it's making a difference for the immune system? You, in a slightly bigger number of people, you wait, you look at the data, and then you decide, well, should we really go with this vaccine or a different one? And then you do the larger 10,000, or in this case, 40,000 people trial. And what we've done in this pandemic is just to move these things as quickly as possible, not to pause, not to wait, and to spend as much money as it takes to keep moving forward these vaccines and testing them. But what the government hasn't done is they haven't compromised on the rigor of the testing. The testing has really looked very carefully at whether these vaccines are effective and closely examined whether they're safe. And so far, the vaccines that are, the one vaccine that is authorized by the FDA, and the vaccines that are coming up really do look pretty safe. There aren't major safety concerns that we can see.
So just today, Governor Pritzker and Mayor Lightfoot were present while 2 healthcare workers got the first vaccinations here. What happens next? How will this rollout happen, and how will regular people who aren't in long-term facilities or healthcare workers be able to get the vaccine if they want it?
I'm going to start by saying there's some unanswered questions here. and if anybody knows the answer to that, then they should speak up. But we're taking this step by step, and I think for all the reasons that we need to. We know that they're starting with healthcare workers and long-term care facilities, and there are plans for expanding to other high-risk groups that have been identified based on things like who we think is most likely to get infected, who we think is most likely to have a problem if they get infected, who is most likely to spread infection if they get it, and who are the people that we really need to have infected so that we can keep operating well as a society. And those are kind of the foundational components as we're thinking about different groups are thinking about who are the next people that get it. I wish I could say exactly like how this is going to happen. And I wish I could tell my mom, for example, when she's going to get it, or my husband was saying, when am I going to get it? I can tell you that it seems like when you hear about what's going on in terms of manufacturing, it sounds like we're going to be moving into January before we get this sort of first group of people, the healthcare workers and the long-term care facility people and the people that care for those folks immunized. So we're probably going to be moving into January and February. People, and then probably later in the spring before it starts to be available for everyone. And there's different kinds of vaccines. So where are you going to go to get your vaccine may depend on what kind of vaccine you're able to receive, whether it's the vaccine that just had an EUA approved, that you're probably more likely to get from your doctor's office or some of the pharmacies that have been supporting this effort, and other vaccines that require less sort of specific storage and things may be more widely available as supply. So there's a lot of questions that are still yet to be answered, which, going back to the piece of trust, I think trust is in the title of this talk. I think it's really important for us as a healthcare community, for our leaders to be really upfront about what we don't know. So what I just gave you was, my best drawing of what the future might look like. But the truth is, I don't think we know exactly the answer to the question, and we have to kind of see how it goes. Unless somebody else knows something I don't.
I think that's all as much as I understand, Kelly. I mean, the other thing that's important to realize is that the plan is to still really track the safety of the vaccine once it starts being given to people. So people will be asked to download an app to their phones, and they will be asked to keep tracking any symptoms they have. And the vaccine itself, as you may have heard, when you first get it, if it's working, it causes a pretty significant reaction. And the second dose seems to cause more of a reaction than the first. So, and Anthony could probably speak to that. But I think that's something to look out for and to be aware of in advance.
Can I just add one thing onto that? Because I feel like some people, when they hear tracking, they start to tense up a little bit. So I just want to backstep a little bit and say, it's really important that we understand what happens to the people who get the vaccine, because we want to know after months how people are doing and whether or not they're still protected. The tracking efforts are kind of in two buckets. One of them are the ways we've been tracking vaccines before this pandemic, just general reporting that might happen through your doctor if your doctor thinks that you've had a reaction to a vaccine, or if it comes up. And there are systems in place that follow that for doctors' offices and long-term care facilities through our VA program. There are sort of a couple of groups. And then the other is what Seema mentioned, which is a new app. And I guess I would like to say, just for those people who might have felt tense when we heard the word track, it is an opt-in in. So you have to say, I'm interested in getting this, and it sends you, it's going to send you text messages saying, are you doing okay? And it provides you an opportunity to report, I'm having a fever or something like this. So I know that idea of tracking can be nervous for some, but I would like to encourage people who get the vaccine, which I hope is everyone on this call and listening to us near and far, that you will participate in this work that's going to help all of us.
So there's a bit of time between non-essential workers and healthcare workers being able to get the vaccine and where we are now. What needs to be done between now and then for trust, whether it's what you plan to do as a professional, or what you think the medical community and government needs to do, at least focused on locally?
Oh, go ahead.
Oh, I was just gonna say, Natalie, if you figure this one out, then you got another book deal. What can be done in 3 months to dismantle hundreds of years of brutality that's been imparted specifically onto certain communities, right? I think we're doing it as best we can. I just, hearing just today, so the first vaccines went into arms in the several states, and there was sort of kind of grand public gestures kind of demonstrating the safety. But I also noticed in the majority of these states, they would typically go find a Black or female physician going into a Black or female critical care nurse, or someone kind of in the face of this pandemic who's specifically at risk. So I can see, gestures like that. Having, former President Obama agree to do this publicly, and President Clinton, those are sort of public overtures that can be leveraged in the short term. But I think we should get ourselves comfortable with the reality that there's in the short term. And I would love it if we didn't miss this moment of reckoning, right? You talked about George Floyd and Ahmaud Arbery and the laundry list of names in the lab, Breonna Taylor. We're at a moment right now, right, where people are listening and paying attention, particularly to issues of social justice, racial equity across the board. And so I would love it if we could leverage this moment to set the foundation for a change in the culture. Right, bold action, right, from both sides, from both communities. I don't know exactly how to initiate that, but I think that's what it's going to take long term to say, hey, we're not going to be able to solve this right now, but we can use this moment to start the groundwork for a playbook that we're going to follow for 20 years until this thing starts to shift.
Can you talk about some things that you think would backfire that should not be done during this period?
That's a tough question. I will say one thing that I've noticed is a lot of groups are really concerned to try to meet this moment and to recognize the inequity in the way the COVID pandemic has affected people in this country. And, one of the ways that people have tried to address it is to say, let's prioritize communities of color, communities that have been hit really hard by the pandemic, and give them the vaccine earlier. I think one thing that I've heard is that some people see that as sort of targeting communities of color and using them earlier on in the process to get more information before it goes to others. And I think that's, the kind of message we want to be clear is not what the earlier movement in vaccines into communities of color is about. Another thing that I think really shouldn't be done, but has been done, is, that we've seen differential access for certain things like monoclonal antibodies, the antibodies that the president got and that Rudy Giuliani got and Chris Christie. And these are really hard to produce, scarce resources that seem like they could be helpful in preventing symptoms and serious disease for COVID. And, what I'd like to see is more fair access for everybody, and not just reserving it for people who have influence and power. So that's, I think, one critical part of this, making it clear who's getting it and why they're getting it, and that it's a matter of prioritizing people and not targeting them.
We have a lot of questions that are coming in, a lot of good questions, and I want to be able to get to all of them if possible. But before I pivot that way, because we have pediatricians here and Lurie workers, what is going on with children? They don't really get to participate in it. It's my understanding that it's harder to get clinical trials for children. So where do we stand with children and vaccinations, and what are the ethics behind that?
I can.
Yeah, it's. Oh, go ahead, Seema. You go.
So I did just want to say the vaccines I'll speak about it from the research perspective, and then maybe Kelly, if you could jump in on the clinical perspective. So what happened in the studies in general is we tend to enroll adults first before we enroll children because they're more vulnerable. And especially with new vaccines, they have to either offer potential benefit to children, or be really low risk before we give it to them. So for that reason, the vaccine trials were really slow to enroll children. And I think another reason that they were slow to enroll children was at the start of the pandemic, children were kind of, schools stopped, children were kept at home. And so we didn't actually see that there were groups of children who really would suffer from COVID, and didn't really think about the need to prioritize testing on them. So now children are being enrolled in many of the vaccine trials. Pfizer's candidate, which is the first one that was authorized, has enrolled children down to the age of 12 and is now enrolling younger children. So those studies are happening, but it means that there will be some delay between when adults can get it and when children can get it. Right now, the vaccine is authorized for people down to 16. So there are some adolescents who can still get it. But it's about getting that information from the trials and making sure that children are enrolling in those trials. And somebody asked about the difference between authorization and approval. That's just there's now this emergency use pathway that the FDA has where they can authorize a vaccine as long as there's a pandemic going on. And they can do it under slightly different standards so that it moves more quickly. In this case, they've really tried to keep the science careful and make sure they have a good sense that it works. But it has come, they've eliminated a lot of the paperwork that they would have to go through otherwise, and they have required a little bit less time than they would usually require in follow-up to make it faster because the need is so great. Kelly, did you want to say more about that?
I would just say, just to add on to the last piece of what you said about the authorization versus the approval. Approval typically, as I understand it, it's a longer process, but it typically has a wider indication or wider field of people that have access to whatever has been approved. The emergency use authorizations and the vaccine, and then also earlier this year, you may have heard the term tied to use of remdesivir or other antivirals. It's relatively narrow groups of people in certain stages of disease where it's been approved at or where it's been authorized at. The approval then allows for a wider breadth of people to be treated with it. So that's part of why kids are just not, they're just not a part of this authorization, right? They weren't a part of the clinical trials. And then obviously for all the reasons that it seemed to just offered.
I just want to add one more thing, which is to acknowledge where we live in the place of history as this relates. So this pathway for emergency use authorization is as young as the atrocity of 9/11. And it was that mass casualty event that made our country aware that we needed to have a process like this. And so this is planning that's coming from that long ago that we're seeing unfold right before our eyes. So we are in history. I guess we're always in history, but it really feels like we're really in history right now.
Okay, so we got to the authorization versus approved. Another question is, do they follow up with the vaccine test groups periodically to check for longer term side effects?
Yeah, so I can jump in, and then obviously Kelly and Seema will be able to come over the top. Just with my experience in being in the trial, the app that I think it was Kelly that referred earlier to, an app that is used to sort of track your symptoms. It's essentially equivalent to like a daily diary. And you go and it prompts you to fill this thing out, and you go in and fill it out. My commitment to the trial is actually for 2 years. So I'm in month 4 of this thing, right? And it requires that I go have a visit and vitals and checkup, have a discussion. And then they also take blood to track for the level of antibodies against the spike protein that we talked about earlier. They want to see how long those are good for, right? And so right now we only know that they're good for at least 3 months, but it could be longer. It could be a year before they tailor off, it could be a year and a half, it could be 6 months. We just don't know yet. So the quick answer to that is yes. I'm committed to this through 2022.
Is there a large-scale federally organized public messaging campaign coming? If so, when? Should organizations wait for it or start developing their own outreach materials and campaigns?
So I will say, I think the federal government, as we've seen with a lot of things in this pandemic, has been a little bit slow to move on this. I'm hoping with the transition to the next administration, we're going to see more efforts. And part of why I'm here today is I think this kind of conversation is really important. And we should be having outreach efforts. One of the things that people realize, though, is that, having it come from the top down isn't that convincing. Just because somebody looks like you, but you've never seen them before, you've never talked to them, and they're telling you that you should take a vaccine, I don't know that would work for me. So what people are trying to do is work with local trusted leaders and answer their questions and make sure that they feel comfortable and then are able to pass that message along. So, I really think it would be a good idea to wait. I think we should all be having these conversations now in our communities and learning what we can and finding reliable sources of information to make sure people know what the vaccine is all about.
I guess I would just add, in our own backyard, the Chicago Department of Public Health is working on information campaign. I'm not entirely sure how that's going to look, but they're definitely in the throes of figuring that out. I think if anyone on this call has good ideas about what that would look like, I would love to know, and I would be open to hearing about that, and would love to pass along that information to everyone that I know who's working on these things, because you guys know what you want, what the information you need and how you need to get it. Like, I would love to hear that.
On an individual level, what, if anything, could a provider say to a patient who is understandably nervous about the vaccine?
Well, now I've got my doctor hat on. I like to ask patients a lot of questions, so I would probably start by asking, what are they nervous about? But since this isn't interactive, I guess I could I could tell you some of the things that have been convincing to me as I've been hearing about the vaccine. As I told you, I'm, and I think Seema can attest, have been a little bit skeptical, to be honest. So what's been convincing to me, I've looked at the data that we have from the Pfizer vaccine. So I'm just going to focus on the Pfizer vaccine. And the side effects that we're seeing from the Pfizer vaccine that we're hearing about, they're there, but they're very mild. Same like you would get in any vaccination. And the number of serious events are very small. So that was reassuring to me. The other thing that was reassuring to me was to hear one of the experts during the FDA panel talk about the history of serious events in other vaccines. And what this person said was that in all previous vaccines, the most serious events happen within the first 6 weeks of getting the vaccine. And we now have 2 months of data on about over 18,000 people. And by the time all this vaccine comes to the larger population, we're going to have more data. And so that will, I think, hopefully also be convincing to people. The other thing, can I add one more thing that helps me feel a little bit better? People talk a little bit about mRNA. It's a new thing. And I think that's part of what scared me. I'm just being honest. Again, as I learn more about the whole mRNA thing, I feel more comfortable, partly because it's new, because it's not been implemented in this way before, but it's actually not new. People have been working on this strategy for medication or therapy and now vaccine development for years. Frankly, it's people that were convinced that this would work that weren't being listened to. So it's a reminder to us to open up our ears and our hearts and our minds when people have a different idea that we need to listen to. So those are some of the things that have been helpful to me.
Someone says that they're understanding, and I don't know if this is true, that everyone receiving the vaccine must provide an address and race, and providing this information is not voluntary. Many people are anxious about this, particularly if they're undocumented. Can you comment on the ethics of that? And do you know if this is true? I think that's maybe the first question.
So Seema will have, you know, as our resident bioethicist, she's going to have way better or way more detailed info on this. I can tell you from my experience, listing my ethnicity or race was optional. And I chose to list that for the reasons that we talked about earlier on. I wanted them to know this is coming from a Black dude. Does this, tell me if it works for us, right? Like I wanted to be a part of that. I think it's part of sort of excuse me, reorganizing or rethinking how we think about our place in healthcare. Yes, know that I'm Black, so when you review these data, you can report that, right? So or that I'm, you know, if I'm undocumented, and that gets into legal issues with, are they going to report you to ICE? Is it? So I don't know that piece. So maybe that's something Seema wants to speak on, but I know at least for being from an underrepresented community, I wanted the representation.
Kelly, do you happen to know if you do have to include your address? I just don't know if you have to give your address. I don't think you do, but I'm not sure. I will say that ethically, I think, you know, it's good to have sharing this kind of information be voluntary, even if the goal of getting the information is to protect people. And I do think it could go a long way to helping people feel more trust. I don't think that there would be any clear way to share information that's gathered in vaccine databases with ICE. So, you know, I think even though I can understand why people would be afraid about that, I don't think that there would be transmission of information in that way.
And here's another question that I have seen pop up as a meme quite often. How do we have a trusted vaccine in less than a year, but haven't found one for the flu, AIDS, or cancer?
Yeah, I can answer this briefly, but I'd love to hear Anthony's thoughts too. I mean, one issue is that certain viruses mutate really quickly. They change quickly. And so flu is like that. It's a really hard target. HIV is a really, really difficult target. So it's been, we're lucky in a way. It seems ridiculous to say that in the context of this pandemic, but the pandemic that we have is one with a virus that isn't changing that quickly. And the critical component of it, that spike protein, is something that we can attack reliably with vaccines. So that's.
No, I was gonna say, and I wonder if people are confusing vaccine with flu. I mean, vaccine with cure, because there is a vaccine for the flu.
Well, I think what they might be saying is you have to get a seasonal vaccine. It's not that effective, right? It's about 30% effective. We're always predicting what's the strain, and there is this goal for a universal flu vaccine, so that all the strains of the flu that you could get protection for that with one shot, and that would last longer than just one season. And what the vaccine that we're seeing right now for COVID is one that is much better than what you would get for the seasonal flu. So if that's the difference they're noticing, part of it is just that the virus itself is different. Another part of it is that we've learned a lot about how to speed up vaccine development, and because our whole world is affected by it, we've thrown a lot of money at this problem. And finally, what Kelly and Anthony were saying, the mRNA technology hasn't quite been ready. People have been working on it and trying to get it up and running, but it's likely that what we've learned about its use in this pandemic can help us in the future with other diseases as well.
Yeah, I think Seema said it was like one of the first things she said amongst all that was all bullet points valuable. So first, the flu, which flu, AIDS, and cancer are fundamentally different diseases, right? And within each one of those even words, right? Cancer, what is, breast cancer is a completely different disease than lung cancer. Has the word cancer in it, but they operate completely differently. Many mutations that drive one disease are not present in the other. Some rely on hormones, some rely on other food to drive a cancer. So the idea that there's something trusted for this, but not for something else, it's apples and oranges. They're two different things, right? Just to give AIDS for an example, the virus that causes AIDS, HIV, is a different class of virus than is the coronavirus. It operates completely differently. It replicates differently, right? And so even using an mRNA type strategy for HIV as a vaccine would have to be reimagined, because when viruses or when AIDS integrates, or HIV, it goes from RNA to DNA. When in other viruses, they go from DNA to RNA, right? So just little, we can get into the weeds on this, on the science. I'm free to do that all day as long as my kids will let me. But just the take home here is that it is very possible to not have something that we trust for diseases that have seemingly been plaguing us longer, simply because it's fundamentally different.
And on that note, that was our last question. And I know that we could keep going and going, but I want to thank all of our panelists for their insight, their knowledge, and their candor. And I'm going to turn it over now to Dr. Nia Abdullah.
Always the muting issue, right? Thank you, Natalie, so much for being here today. I am Dr. Nia Abdullah, MAPSCorps' new executive director, and I am so honored to join an organization impacting so many young people in Chicago, New York, and North Carolina. We decided to host today's webinar because so many of our young people have asked myriad questions about the vaccine and admit to having family members hesitant to take it. As we know, African American and Latinx people have disproportionately died due to COVID-19. And as an organization, we thought it critical to answer some of their questions in a forum they trust. I am so grateful to Natalie Moore for taking the time from her day off in order to moderate, to our esteemed panel, Dr. Shah, Michelson, and Williams, for taking time out of their very busy schedules, and to the Chicago Ethics Coalition for your partnership. MAPSCorps will continue to host conversations focused on health, science, technology, engineering, and mathematics, inspired by our youth alumni, to bridge the gap between what young people see and hear on social media and what the experts have to say. Finally, if you haven't completed your end-of-year giving, please consider MAPSCorps, a 501c3 nonprofit organization. Thank you everyone so much. Stay safe and happy holidays. Have a good day.